This is a project which has been incubated here at the CSIR over the last 5 years, not in the last year and a half, but before that. And it was introduced as an initiative of the National Department of Health when, for a period of almost 20 years, there had been no guidance and no law guiding healthcare infrastructure. In about 2007, 2008, government took a look at the healthcare infrastructure and reflected that there were a number of critical problems and introduced a number of initiatives to try and address some of these problems. So I'm going to discuss the norms and standards as a way of addressing some of the issues that are raised and some of the challenges in healthcare infrastructure. And then I'm going to ask that if we were to implement these, and it takes us 40 years to replace the building stock that we have at the moment at the current replacement rate. So in 40 years' time, once this is all rolled out, will we end up with a healthcare infrastructure which is lean, in other words, which is efficient and which has value for money, and which is sustainable? In other words, is South Africa's healthcare estate going to be a lean, green machine by introducing guidelines, norms, and standards? In our research group, we believe that service delivery is profoundly affected by the built environment that's made to support that delivery. Sometimes, in fact, and I will discuss that, the infrastructure can actually not be an enabling situation, but a part of the problem. Parts of the issues that were raised when government did a review of its infrastructure is that there were huge variations in quality of infrastructure delivered and concerns about quality, unexplained variations in cost, and capital projects were getting stuck somewhere in the process a lot of the time. So the infrastructure norms and standards were meant to address some of these issues systematically in the public sector for healthcare infrastructure. So why didn't the South African government just go and borrow a set of mature norms and standards from somewhere else? And I'd like to discuss some of the key contextual issues that our healthcare infrastructure face that make it appropriate for us to have developed our own. We have a unique starting point, an interesting split between private and public sector. We have a unique demand profile. We suffer from a different range of diseases than where the health care guidelines, norms, and standards from international use originate. And we actually have a range of constraints and opportunities which we need to use in order to flourish going forward. I just want to say that health is recognized to be a very important public good generally in the world, but according to the United Nations Inclusive Wealth Report, South Africa is not on a sustainable trajectory. And part of the reason that it's not on a sustainable trajectory is because of our poor health outcomes, and also because of our early death rates. Now, there have been some important developments recently, but a healthcare infrastructure is needed to support this and to improve that, and it's fundamental to our success and sustainability as a country. I'd like to describe these two sectors that I've mentioned, the private sector and the public sector in our country. The private sector is market-driven. Its infrastructure reflects a brand consciousness. It must remain viable, and so it has an imperative to minimize capital costs. Therefore, comparing the capital cost of a public and a private sector building may not always be appropriate. It replicates its successes by repeating patterns and experiences which worked well. And it develops in-house capacity. So it gets a set of consultants who, through the process of repeating projects and incrementally improving them, actually get better and better at making healthcare infrastructure. And because it is relatively autonomous, the private sector is characterized by being agile and responsive. And here is a typical private hospital building in South Africa. The public sector is different to this, fundamentally different. First of all, there are a number of role players. As Marty mentioned, we have national, local, and provincial governments who all stakeholders in the infrastructure. And we have public works and health departments, one of which has a role in the infrastructure and one of which is the user of the building. This is a very important point because architects and engineers do not have training around healthcare-related issues in their undergraduate programs at all. They may not be sensitive to the special needs of this subspecial kind of work. In the public sector, there's an economic imperative to minimize operating costs, but the capital costs can be better invested to be more robust, more resilient, maybe less maintenance intensive. In fact, that's quite a useful approach because government has demonstrated a track record of being maintenance averse. It's got a roster-based professional selection process, which is very fair, but it disincentivizes becoming a specialist in healthcare infrastructure because although you may get another project in another field, you have no way of anticipating that you could specialize in that field and receive ongoing work. And the processes are cumbersome. The Gauteng Department of Infrastructure Development followed an invoice from issuing to being honored through 53 discrete phases. That is expensive and it will result in delays. But at its best, our public hospitals, and this is one example, there are many, are brilliant. They are beautiful world-class facilities. The thing is, a lot of our facilities are not at all like that. There are much more, especially in the public sector, which look a lot more like this. And this is unsuitable for use as a healthcare facility because the materials are not conducive to dignity and privacy while you're being consulted. It's common practice in hospitals in South Africa to have two simultaneous consultations going on in the same room because of a lack of space. You can't maintain this material adequately, although it's probably provided as a temporary solution. Unfortunately, that often doesn't materialize. And often these buildings are difficult to access for people who are ailing, who are infirm, you know, the kind of people you usually find at a hospital. So we're saying that the private sector and the public sector have, at their best, comparable infrastructure, but at their worst, not great. What is going on? So Treasury in 2012 reports that the spending is roughly split 50%, 50% private to public. 122 billion rand is spent in each sector. But in the private sector, that's only in the service of 16% of the population, or 8.2 million people, whereas in the public sector, the service is for the benefit of 84% of the population. No wonder the infrastructure is failing. We have a quadruple burden of disease. There are lifestyle diseases, child and maternal mortality, violence and trauma, and infectious diseases. And I'd like to just quickly focus on one of those, TB, because it's got an interesting dimension in terms of the built environment, which I'd like to go into how research has supported the norms and standards development. TB is a big problem in South Africa. It's the single biggest killer, and it kills about 9% of, it accounts for 9% of deaths annually. It also is an airborne disease, meaning that the quality of the environment matters to how the disease is conveyed. This can be shown clearly in research which shows that healthcare workers have between 4.5 and 135 times increased risk against the background population of acquiring TB. This is a clinic in Tshwane which has no windows and no mechanical ventilation. This is a map which is distorted to show where TB occurs in the world. The bigger the landmass, the more TB. And you can see South Africa is a swollen tip there. And here, marked in red, are where the international standards for healthcare infrastructures originate. So you can see that those are the places which do not suffer from TB. I hope TB is a transient problem, and then we can just adopt international standards. But in the meantime, we need to adopt standards which are contextually sensitive and which are evidence-based or based on current best practice. The Norms and Standard Project has 46 work areas, documents, and software tools, which are hopefully sitting on somebody's desk, even more hopefully being implemented. They have a non-prescriptive approach and have been called mandatory in the public sector only, which is an interesting thing, and that has been through a number of gazettes in 2014 and 2015. And they are applicable for all prospective buildings. In other words, that clinic with no windows and no mechanical ventilation does not necessarily need to go and be fixed. And as I said, it's only applicable in the public sector. There's been an open source dissemination of this guideline through a website, www.iussonline.co.za. And we've had an unfortunate natural experiment with this website, because when the project came to an end in 2014, in March, for a number of months, there was sustained visiting of between 2,000 and 2,500 unique visitors to the website every month, and on average, 18,000 page downloads. 80% of that traffic originates in South Africa, meaning we have impact where it's intended. A year later, without sustained work on that, the unique visits had dropped to less than 600 a month, and the number of page downloads to less than 3,000 page views. And the distribution of interest shifted away from our local use. We can measure this, and we can see that not supporting ongoing development here has a profound impact. The Honourable Minister, Naledi Pandor, said, the benefits of our research do not naturally accrue to the people of South Africa effortlessly or automatically. And she's right. This shows very clearly that she's right. I'd like to talk a little bit about what the content of these norms and standards are. My hero is not Einstein, it's Florence Nightingale. And she said 150 years ago that the first principle of hospitals is we must make sure that they do the sick no harm. And 150 years later, with that TB situation and our built environment professional situation, you can see that this still remains a very important tenet. We need to make sure we have value for money. We want lean, efficient healthcare infrastructure, which has got the maximum benefit for the South African population. And we have to look at this sustainability agenda and how we can make things green and legible. This, how am I doing for time? Okay. This is a a very interesting research project, which I'd like to talk about for a few minutes. It's the Sydney Parsons Air Facility in eMalahleni. It's a unique facility in the world. It's a drug-resistant TB facility. Patients are recruited into a research facility, and the air that is taken from the patient wards is put into alternative chambers on alternative days. And then various transmission mitigation strategies are tested in this real environment. Excellent research in that area with a number of collaborators has shown that simply wearing a surgical mask on patients can reduce transmission by 50%. That is a cost-effective measure, and we now are able to quantify through this research project what the efficacy of it is. Similarly, we can show that upper room UVGI, ultraviolet germicidal irradiation, which you can retrofit into clinics like that one without windows, can reduce transmission of TB by almost 80% under ideal conditions. In this picture, where we're looking at a portable filtration device, we were modeling it here using computational fluid dynamics because we tested this in this facility and found it only to be 20% effective. We didn't believe it, we ran the experiment again, and still only 20% effective. So we can use an evidence base to guide policy. But this is digressing a little bit. We want to make sure that we have value for money, and we've developed a number of cost model tools, order of magnitude estimators for both greenfield and brownfield capital work. It tells us about what the costs to expect for clinics and hospitals. There are more detailed estimators which are more accurate for later on stages within the program. The maintenance estimators, they show cash flows so that you can budget well, and operating costs, including for equipment. These get updated quarterly for inflation and for exchange rate factors because it includes equipment. I want to talk about an exciting project which I think I'm running out of time. Yeah. I want to talk about this exciting project very briefly. We say we want to provide sustainable buildings, and we can provide targets for emissions and consumption. But it's difficult not to make permissive targets because in Sutherland you have to heat a lot, whereas you can use passive design strategies nicely here in Pretoria where it's pretty perfect outside. So in order to make sense of our climate, it needs to be characterized, and this is being done with NRE. Very soon, this will be able to be accessed by built environment professionals through a portal, which we're busy building. Finally, we've spent a lot of time looking at the processes and workflows that occur within a hospital setting and describing those in wonderful detail. And this should get the conversation going between healthcare professionals and built environment professionals and streamline those processes. We've even gone and showed how those processes might work out in flows and so on. But one has to acknowledge that there's a problem with this because, first of all, it takes 5 years for something to get from an idea into the built form when it's going very well. I'm sure Marty will agree. And in fact, the problem is we're embedding 5-year-old or 10-year-old technology there. So there's telemedicine. You can get your defibrillator delivered to you by drone when you're suffering a heart attack. You can get your medicine delivered to remote areas. You can get samples collected and taken to labs. You can get labs reduced down to microfluidic, tiny pieces of equipment instead of entire rooms. But we're going to be building something that is probably at least 10 years outdated. The only antidote to that is to maintain what we have already invested in. And as I may have mentioned, some of our infrastructure we're going to be living with for a very, very long time. We have 47,000 hospital beds. There are no international standards about how many beds you should have. Here we have 0.9 beds per 1,000 people in the public sector. In both the public and private sector, considered together 1.6 beds per 1,000 population. That compares to Brazil's 2.3 beds, China's 4.2 beds. We basically kind of align with India on this. The World Health Organization defines health not merely as the absence of disease. These norms and standards that we've been talking about are actually norms and standards for sick care, not health care. The built environment is actually very broadly implicated in the health of a nation. It's not just about what happens to you when you become sick. Obviously, sick care is going to be a very important part. But how do we make our cities so that exercise is safe and part of normal everyday life? How do we configure our built environments to support health in the sense of vitality, longevity, and wellness, and not merely the absence of disease? We need to build the right thing in the right place at the right time. We need timely, integrated strategic planning. We need to invest in resources, in capacity, both in the health sector and in the infrastructure sectors. And research has got a crucial role to play in collecting and organizing and using that information. I'd like to acknowledge a number of international local collaborators. I have a great team at the CSIR who I work with. We've involved a number of leading local experts in the development of these norms and standards, government and academic stakeholders, voluntary associations, particularly the South African Federation of Hospital Engineering, a number of NGOs, and we have been blessed to have had good funding to support this work.